Hello and welcome to the 2023 Healthcare Forum, presented to you live by Long Island Business News. I'm Joe Dowd, editor and associate publisher at Long Island Business News and your host for today's forum. In this year's Healthcare Forum, we're discussing a range of topics focused on how healthcare as an industry is shaping our economy and future workforce while making our communities better. We will dive into how the healthcare industry is tackling issues beyond the ER, like responding to mental and behavioral health issues, as well as food insecurity. This forum is being attended by hundreds of business people and industry experts across the country, and we couldn't have welcomed such a distinguished crowd without this year's forum partners, who are integral to crafting this year's panel discussions. Many thanks to our presenting sponsor, Catholic Health, and our partner sponsors, Harris Beach, the New York Institute of Technology, and Central Nassau Guidance Center and Counseling Services. Again, thank you to our sponsors in making this year's Healthcare Forum impactful and informative. To kick off the 2023 Healthcare Forum, LIBN tapped into one of New York's rapidly growing healthcare systems. I got to sit down with Dr. Patrick O'Shaughnessy, President and CEO of Catholic Health. We had a chat on Catholic Health's response to food insecurity and how the growing hospital system is expanding its reach across Long Island. We're here today with Dr. Patrick O'Shaughnessy, the President and Chief Executive Officer of Catholic Health. Sometimes everyone around him refers to him as Dr. O. Dr. O, thanks for joining us today on LIBN and for this important forum where you are the keynote speaker.
Joe, thank you so much. It's truly an honor and a privilege to be with you here today. And I'm also honored to be the keynote for Long Island Business News on this very important topic. It's great to see that you have a healthcare forum and excited to conduct our interview together.
Start out with something that is on the mind of many Long Islanders, but is sometimes hidden. It is the question of food insecurity and how it relates to health. If you would, Doctor, paint the picture for us of the face of food insecurity on Long Island.
Yeah, absolutely, Joe. It'd be my pleasure. Let me just first cue up, who we are. So Catholic Health is a health system that spans Queens, Nassau, Suffolk. We're number 2 in size and scale. We have over 1,900 licensed beds across 6 hospitals, 3 nursing homes, home care, hospice. We care for anywhere from between 20 to 22% of the Long Island market, and we're growing. So we have a really strong footprint on Long Island. This is where we operate. This is where we live. Thanks so much for bringing up the topic and the concern of food insecurity on Long Island. And I think it's a big problem, quite frankly, nationally. I think it's a problem within New York that's, we're all working hard to address. And currently in New York, there are over 2.4 million people facing food insecurity. And when you break the numbers down, that's about, 230,000 people on Long Island, 68,000 of which are children, and 4% are seniors. And I think what really we saw across the health system and across the island is that the pandemic, what happened with COVID-19, really exacerbated the issue.
You said that you have come to a program where you actually give out bags of food,
Yes.
Supplies. I mean, how does that make you feel? We live in one of the most well-to-do communities in perhaps the world. This is Long Island, and we have people that hungry. How does it make you feel, and what do you think we should do about it?
Yeah, it's a sad state because, to your point, and as we discussed before, Joe, in this country, we all should have access to good, healthy food. We have over 200,000 people visit our emergency rooms each year. Let's screen them. Let's ask them in a non-judgmental way, is this an issue for you? And if so, if you screen in, let's begin to help solve the problem. So every patient that comes into one of our 6 hospital emergency rooms gets screened through our hunger vital signs assessment tool. It's actually tracked in our electronic health record, so our teams can ask these questions easily. And then if they do screen in, we have food to go bag that's in a partnership with Long Island Cares. And so I would invite anyone who listens to this talk to say, work and partner with your community-based organizations. Even though your sphere of influence may be in a particular space, when you come together, you can do really great things.
Let's talk about the future a little bit.
Yeah,
We
sure.
We see Catholic Health building, expanding, doing innovative things. Can you give me an idea of what is informing this building program? What's telling you it's time to grow?
Yeah. Thank you, Joe. So I'm very excited to lead Catholic Health into its future. I think our future is very bright. My vision for healthcare is we want to be the best place for folks to receive care, period. We may not be the biggest, we will be the best. And to do that, we have to have the very best and most talented workforce. We have to offer state-of-the-art care, but we also have to grow and expand and make key investments in brick and mortar and new locations with state-of-the-art facilities.
The president and CEO of Catholic Health Services. Thank you very much for joining us today, Doctor.
Joe, thank you and Long Island Business News very much for this opportunity. It was a pleasure to speak with you today.
Well, that was just a small snippet of the exclusive one-on-one interview LIBN conducted with Dr. Patrick O'Shaughnessy. To watch the full interview, head to longislandbusinessnews.com. That's LIBN.com/healthcare forum after the program. Now, we move on to our first live panel session of the day. Now, more than ever, the need for mental health services is great. Hear from our next panel on how the healthcare system is turning to nonprofits for a helping hand. Please welcome our panelists. Martha Carlin, Director, Long Island Field Office at New York State Office of Mental Health. Robert Detour, CEO, Advanced Health Network, Recovery Health Solutions. Kathy Rivera, CEO, North Shore Child and Family Guidance Center. And our moderator, Jeffrey Friedman, CEO, CN Guidance and Counseling Services. Jeffrey, floor is yours.
Thank you so much, Joe. We really appreciate it. We're excited to be here today to talk about the mental health crisis here on Long Island. As we emerge from the pandemic, the mental health crisis on Long Island continues to grow and reach epidemic proportions. At CN Guidance, we've been doing this work for over 50 years. And over the last couple of years, we've seen a dramatic increase in the rates of depression, suicide, anxiety disorder, PTSD, in addition to the increase in substance use disorder. The panel we designed today brings together Long Island's leaders and experts who map out how to address Long Island's mental health crisis and how services are being reinvented to dramatically change how Long Islanders access treatment. I think most of us can agree that the US healthcare system is broken, fragmented, and expensive. Pre-COVID, the US was spending about 20% GDP on healthcare. Canada and European Union is about 10%. Over the last few years, we've seen providers work hard to fix a broken system by working towards utilizing a triple aim model framework. Aim 1, improve the patient experience of care. Aim 2, improve the overall healthcare of the patients we serve. And Aim 3, reduce overall healthcare costs. Simultaneously, funders have been moving towards a value-based care reimbursement. The value-based care is a form of reimbursement that ties payments to the quality of care provided and rewards providers for efficiency and effectiveness. The traditional model, known as fee-for-service, simply assign reimbursements based on services healthcare organizations provided, whether or not the patient really needed them at all. But in a value-based care reimbursement model, it's contingent on the quality of care provided, and it's directly correlated to the patient's outcomes. Value-based care benefits include reducing healthcare spending and better overall health. Treating people's mental health is pivotal to effective physical health outcomes, and addressing mental health and physical health together is best practice. Everything from managing the right medication to cultivating an attitude of resilience and medication compliance. Studies have shown that addressing mental health conditions early, that the average cost of a high utilizer of physical health can be reduced by 33%. Research makes a compelling case for early identification and intervention to address mental illnesses. So we'd like to kick off this panel with a question. What is one thing that we can do better to integrate mental health and physical health? And Bob, maybe you could address that for us.
Well, what I wanted to do, Jeffrey, just kind of going along with you, the path you were on was, and since this is Long Island Business News, was again to make the business case or the value proposition for behavioral health. And when I say behavioral health, I mean those what people would normally perceive as persons with mental illness receiving care, and also persons receiving substance abuse disorder care. So like you said, when you consider the costs, last 2021 were $4.3 trillion for healthcare, $12,900 per person in the country. Any impact in that quality or cost would be certainly welcome. Research clearly indicates that the advancement, especially with the advancement of the information technology, that when you integrate or include behavioral health in your primary medical care delivery system, you impact the quality of care. You also change the utilization patterns away from the emergency room and inpatient care. And you also significantly reduce the cost, especially for chronic conditions. So when you consider these three outcomes of integration, the value of integrated behavioral health appears to be significant. A quick example, proof of concept, is Intermountain Healthcare. That's a system of hospitals and clinics that serve the seven Midwestern states. They have 3,000 physicians, 225 clinics, and 24 hospitals. Intermountain also operates a health insurance company. So anything that would change in terms of protocols that would improve the cost and improve quality would certainly be a win-win both for the insurance company, the healthcare system, and most importantly, the patient. Intermountain decided to try or integrate on their outpatient services, integrate behavioral health into their standard operating protocols. So they chose a subset of clinics where they integrated the mental health team, and they compared it to their standard operating protocols where they do not have that team. And both the clinics they chose selected a group that had the same demographics in terms of the population that was being treated. After 36 months of operation, the analysis concluded that for those individuals receiving care at the integrated site, there was a significant increase in quality, there was reduction in use of emergency rooms, inpatient settings, and a significant cost reduction. Based upon the figures in the analysis, the cost for those patients who received the care at the integrated sites was $667 per person less per year. Now, that may not sound like a lot of money, but when you're an insurance company or you're a healthcare system or a country that's providing care to millions of people, $667 per person for Intermountain totally could impact about $667 million in savings. It wasn't the medical director, the behavioral health, who asked for more of the same. It was the chief financial officer. So behavioral health clearly plays an essential role in improving quality and the utilization of changing the utilization patterns for care, and certainly impacts the patient satisfaction. So that's kind of a quick proof of concept in terms of behavioral health's impact.
Excellent. Thank you, Bob. And so, Martha, maybe you can kind of piggyback off of that. You have a different perspective, seeing things from, the state at the Office of Mental Health talk about this idea of integration of mental and physical health and where the state is, kind of what the vision is. Mother, I think you're on mute.
Thank you, Jeffrey, and thank you for having us here today, in this very important discussion. As I think hopefully most people know, Governor Hochul has invested close to $1 billion at this point in mental health. And, kind of one of the things that, kind of she is looking at is, how to have more services in the community, and that idea of integration, kind of being critical, especially when it comes to children and families, right? Kind of because we're not talking about just mental health, but again, I think as Dr. O'Shaughnessy just said in his presentation, food insecurity, is something that also needs to be considered. Physical health, emotional health is something that needs to be considered. So certainly working harder to also just bring services, kind of to the community and to children and families, adults, so that we can avoid, them having to go into emergency rooms and avoid having to, kind of impact on the system in a way that is not as emotionally healing, I think, as it is to get those services in the community.
Oh, excellent. Thank you, Mark. And so, Kathy, you bring a unique perspective to kind of the work that we do. You deal with children at North Shore Child and Family Guidance Center. How does either the lack of integration in the folks that you're seeing affect the people that you serve, and how can we do a better job of integrating physical and mental health together?
Yeah, so Jeffrey, again, thank you for having us. I think my perspective as a provider, right, where families come to us or we reach out to the families, right, in the community to prevent a crisis from further escalating or from occurring. I want to echo what my colleagues have said, as well as Dr. O. Screening is key. It doesn't matter what reason led the families to come and ask for help. You need to treat the family and the child in its full ecosystem, right? So we provide mental health services to children and substance use issues, but what were the pathways to needing that help? And so being able to screen and look at what's called social determinants of health early on is key. It's beyond just even, food insecurity, it's housing stability, it's financial stability, right? At an all-time high of inflation. It's being connected to your community. So when we as a provider, say goodbye, you have the support still there to be there for you and to ensure that another crisis does not occur. And so I think being able to use best practice as a provider, asking those questions up front, and then us as a provider taking it to another level of collaborating with others, because nonprofits can't do it all. When you've seen one nonprofit, you've seen one nonprofit, right? Their specialty is their specialty, but they can't do everything. So being able to partner with insurance companies, with our regulatory bodies to ensure that we're meeting the family needs, I think is key, right? It's also that concept of treating the child independently without their family. That's not something you can do. It has to be sort of well-rounded.
Absolutely. So Kathy, you talked about collaboration, and I know, Bob, you've played for decades a role in terms of here on Long Island, getting providers to collaborate together. Maybe you could talk about, the last few years you've been working, at the IPA, and how you've been working with providers, nonprofits and for-profits for that matter, to collaborate on better, population health for people.
Well, the IPA is a group of about 42 providers on Long Island. And it really was, the impetus for it was from the Office of Mental Health and the Office of Substance Abuse, or I said OASAS and OMH, to try to bring the provider system into the newer world in terms of technology and prepare them for the value-based reimbursement program. And to engage in a value-based reimbursement program, you really need to be able to have data, have outcomes, and have a much more scientific focus and rigorous focus on how you're providing care. What's happened in terms of the collaboration is because when you get a larger group of people together, you have a larger N of patients that you're serving. And you begin to look at, and using the technology, look at the outcomes, and you're able to begin to provide or identify patterns of care that seem to be better than, or at least best practices. So our effort has been to try to begin to help our providers and networks among these 42 providers to get regular reports to see how they're performing, see how their patient outcomes is, and bring them together so we can improve the care and have better outcomes. Again, affecting the outcomes similar to Intermountain, reducing ED visits, inpatient care, and keeping people in the community. And also we've been able to identify, as Kathy was talking about, and Dr. O talked about, the importance of the social determinants of health, which are food security, where a person lives, access to transportation, and access to good health care. So that the collaborative effort has been, I think, relatively successful, while we're still in the stages, and change is hard. One of the biggest challenges I think we have is getting proper financing for a lot of these providers to make that transition. Because clearly, if we're able to make the transition that the data and the collaborative efforts are showing, we'll have a better return in terms of patient outcomes and also cost.
Absolutely, absolutely. And what we've also seen, we've seen you talk about changes kind of, in behavioral health. And maybe Martha, you can talk about, when the pandemic first started, I think that we never imagined 3 years later what kind of changes behavioral health organizations would have to make. We could talk about, Martha, the use of technology and how we've pivoted very quickly as a sector to reach people in need.
Right. Sure. One of the things that sometimes government gets criticized for is that, kind of we take too long sometimes to make things happen. But I think COVID was an example of how, kind of we really changed the focus of healthcare, because what we realized very quickly is that we needed to find a way to make sure that our providers could stay solvent fiscally, and that we could still be providing care, to the individuals that needed it in a way that was safe, kind of for everyone. So I think telehealth is the way that started. And I think of Bob Detour as a little bit of a visionary, because I remember like 10 years ago when I started in this role, he was one of the first to be promoting telehealth. And I think everyone was a little skittish about it. But what we have found is that really it has been transformational in terms of healthcare, because it has allowed people who, well, obviously during COVID, kind of when we knew that it wasn't safe for people to be in contact, it provided a forum for people to be able to get the treatment and the help that they needed. I think one of the things that we have to balance that out with, though, is, kind of balance that between using it judiciously, kind of using it in a way that serves the people who need the help, but recognizing that there are some people that, really do need to be seen in person, kind of, and do need to be assessed, kind of more carefully. And, but again, I think it has been just a system. And one of the things that I think the government's role in this is going to be is, as we know, OMH is not just a provider of services, but we are also a regulator and an overseer. And so one of the things I think as we move forward that's going to be critical is for us to balance, kind of the needs of the individual with the technology, and ensure that it is really basically functioning as optimal a way as possible.
Absolutely. And I know, Martha, we've had this conversation before in terms of viewing kind of telehealth as just another tool in our toolbox to reach people. And when people need to come be seen in person, we do that. If they're more comfortable being seen, via telehealth, we can do that too. It's just another option that we have for people. So Kathy, maybe you can talk about, your experience as a provider, what that was like in terms of being able to pivot so quickly to be able to see people during the height of the pandemic.
Yeah, so, similar to what everyone has been saying, it was a blessing and it was scary, right? I think everybody reacts to change in a very different way. I think for our clinicians who have been doing this for a long time, there was a worry behind it and being able to use it effectively. So as a provider, we learned very quickly that not only did we have to have a decision matrix in place to use it to ensure safety and to ensure good quality care was being delivered, we also had to train our staff, right, in a very different way to be able to use it. We had to train our families also on how to receive it. I think one of the things collectively as an organization we were very happy to see is that it created a sense of equity and reduced access barriers. we noticed, obviously Black and brown communities were not able to have this before. And now they were in a very different way, which honestly shouldn't have been the case, right? The first part of it should never have been the case. Everybody should have access to care. And we work with children. It's always hard for me to hear cost when you talk about children. It's an investment, right? We know when adults are not well, their physical health is not well, and they're more expensive. So why not invest in children, right, early on? So, being able to quickly mobilize our staff, access the technology, and be able to train, I think was probably the biggest hurdle for us as a nonprofit. We clearly got through it, we've mastered it, and we're very grateful for it. I think also, the data definitely showed you had much more engagement with this extra tool in your tool pouch, right? So things like snowstorms on Long Island didn't impact care. Single mothers who had multiple children with special needs were now able to participate more actively in services because they didn't have that parental stress of trying to get to us. We're talking about a very vulnerable population, and being able to make things easier for them was really an honor for us to be able to do and to answer those calls and serve more.
Absolutely, absolutely. And so, I mean, I think, we've been through a very traumatic time with COVID, and a lot of things have changed. The silver lining is it forced us to change for the better in some cases. And I think that, agencies, nonprofit agencies have learned that, we can make that pivot, and we can make it, pivot quickly. And I think, we started off talking about value-based care, and some of the challenges that nonprofits had faced for a long time is sustainability. How can we, sustain the services that we provide? And being able to, cast a wider net, telehealth certainly opens up more doors for us in terms of serving, different populations and increasing access to care, et cetera. And so when we look at more sustainable, financial models, maybe, Bob, you can talk about how, the value-based care model might be the model that allows, nonprofits to sustain themselves in this kind of environment moving forward.
Well, value-based care is the opposite of volume-based care.
Yeah.
So just so everybody understands that, right now, people are paid by event, and value-based care is an effort to pay by outcomes. So we've been doing some things with some of the managed care companies, one of them in particular, trying to create bundled rates, where we have put together, and this has been on the substance use disorder side, that we're experimenting with the healthcare system, with the healthcare provider or the insurance company, where we put together a bundled rate so that the provider doesn't have to do X number of visits, doesn't have to do X number of calls or site visits, whatever. They have to focus on a plan that has measurable outcomes, such as the emergency room use, inpatient use, community sustenance, making sure that they get their medications on a regular basis, and good housing. So that's the type of opportunities I think that exist for the behavioral health providers as we go forward, as we work more with bundled rates. Very difficult and very challenging for behavioral health because there's so multiple variables in terms of trying to create a rate. But I think as we begin to show some of this success in terms of outcomes and total cost of care impact, and we have to address that because that's part of the business, the reality of the world, that I think that behavioral health will have a greater opportunity to work with the primary medical system, and where the savings occur. The significant savings for behavioral health investment occur in the medical side, not behavioral health. But those savings can be used to finance better behavioral health care. And that's what we're trying to do in terms of the work with the managed care companies.
Absolutely. And I know, Martha, the state is kind of envisioning value-based care as being, a part of this, fiscal sustainable model moving forward.
Yes, absolutely. It really has to be. Absolutely.
So, I think, when we look at some of our challenges, I think we'd be remiss if we don't mention some of the, issues that we're having around workforce. And that has been a tremendous issue for providers. I know, here at Seeing Guidance. We've experienced that, and we've seen that on all levels of staffing. Hiring, recruiting, and retaining has been a challenge for us. Kathy, maybe you can talk about some of the challenges that you've experienced and how you've gotten, you're working to get around those challenges or work to fix those.
Yeah, so I think that I just want to level set that and also say it's beyond just even the healthcare industry. I think workforce in general, we can go back to the remote work. While it's been a blessing, it's also been a curse. You find a workforce that prefers working fully remote, and the nature of our work is not solely remote. So being able to be creative with some of our staffing models and allowing sort of that flexibility where we put them into sort of different categories of staffing of, folks who could be hybrid, folks who are remote only, and then folks who are 100% on site. And being able to be very creative with that kind of scheduling, making sure that we have staffing models that fit purpose. A lot of other things that we've been trying to do is looking at our workforce, right, and really investing in their wellness. The pandemic was a collective trauma for everyone, right? No one was immune. And so our staff were impacted just as the families that they serve. So really being able to look at ensuring our staff wellness is key. Looking at paying very close attention to our attrition rates and the why. Being able to build up our pipeline. We've been doing more and more work with our local educational institutions to ensure that they are building a pipeline of potential future staff for us, and inviting us to speak with students that are on these clinical tracks to better understand what nonprofits do, what our work looks like, the social impact it makes on the communities, and that, this notion of, getting a degree and just going into private practice is just really not for everyone. It doesn't really serve everyone. You're not making quite the impact that you thought of. And then just sort of trying to be very creative with understanding the why, right? What attracts folks to this kind of work in terms of making a difference for children and families, particularly within the Long Island community. We've also tried to look at really bringing on more evidence-based models that younger folks that are graduating are more attracted to, and being able to sort of offer that to them. Knowing that it takes several years to not only learn the model, train in the model, but truly master it. As a nonprofit, we've had to learn to redefine retention. We're 70 years old. Once upon a time, longevity was 20, 30, 40 years. Long gone are those days. And so we've had to sort of shift with that culture. But really also looking at competitive salaries whenever we can. As nonprofits, that is a difficult thing to do. But we put our boards to work, we look at our strategic plan, and we try to level set whenever we can to keep that talent in-house.
Excellent, excellent. So this panel has gone very quick. We have about a minute left. And so I just want to end with maybe Bob, Kathy, and Martha, you can just quickly tell us, what does the future of behavioral health look like here on Long Island? What can we expect?
I think certainly from a government standpoint, the future is a lot of new and innovative programs, some of which already exist. Additional crisis services, you're in the process of building a crisis stabilization center, a lot of ACT teams, a sort of community treatment teams, kind of like expansion of clinic services. So again, understanding that the challenges that Kathy brought up are very real in terms of staffing. But the hope is that with the appropriate funding for these programs, kind of that we are going to expand capacity. 988 is the other thing that I would be remiss if I didn't mention, that, okay, it is an ability for everyone who is in distress to be able to access help and get referrals when they need it. So it's actually a very exciting time to work in mental health, and I'm really proud, to be working here.
Excellent. Well, on that note, I'd like to just thank Bob, Kathy, and Martha. Not only are they good colleagues, but I think today they gave us a really robust conversation about, behavioral health and some of the challenges and where we're going with it. And so thank you very much. And back to you, Joe.
Joe, you're on mute.
Very good. Sorry for the delay. We want to thank our panelists very much for partners at CN Guidance and Counseling Services. Excellent conversation. Our next panel will explore how our education systems are shaping the next generation of healthcare workers. Please welcome our panelists. Dimitri Jean-Louis, an alumnus of New York Institute of Technology. John Caraptis, an alumnus, New York Institute of Technology. Dr. Donna Marie McMahon, Associate Dean of Student Affairs and Associate Professor, College of Osteopathic Medicine, New York Institute of Technology. And our moderator, Gordon Schmidt, School of Health Professions, Dean, New York Institute of Technology. Gordon, please take it away.
Thank you very much, Joe, and thank everyone from the Long Island Business News the opportunity to share with you a fantastic panel. And it's a great segue from the previous discussion about mental health, where they talked about workforce. So to begin with, our topic is the workforce development, shaping the next generation of healthcare professional. And to do that, I've invited several of my colleagues from each of the disciplines that are very truly involved in healthcare. Dr. Donna Marie McMahon is a medical doctor. Dimitri Jean-Louis is a nurse, and I'm going to ask them in a moment to introduce themselves and give a little background. And John Caraptis is a physician assistant. So as we've learned just recently from the last presentation, much of the future of healthcare involves training. Sometimes we find that the need for employees does not meet the availability. It's estimated there are probably 500,000 employees still needed in healthcare. And possibly because of the pandemic, we see that this is more critical than ever in the past. Approximately 16% of hospitals have critical nursing staffing shortages, not just in nursing, but all the disciplines. So let's take a moment and find out who our other panelists are. I'll ask each one to provide a little bit about themselves, their name, their background, affiliation. And then if they wouldn't mind passing to the next person on the list, we'll start with Donna, then John, and then Dimitri. Donna.
Okay. Good afternoon, everyone. I am Donna McMahon. I'm a graduate of NYIT-COM. I graduated in 1987. And as much as I tried to get away from Long Island, it kept sucking me back in. 2 years of my training was at NYU Long Island. Then I tried to get away again and ended up coming back in 2003, where I was in private practice, and then joined NYIT-COM, the College of Osteopathic Medicine, in 2008, and have been here ever since and raised my kids here. So as much as I wanted to get away, it got me back, and I'm very happy that I'm on Long Island and able to have an impact. I'm an associate professor of pediatrics, and I see patients in Central Islip, a high-need, low-income community, in one of our academic healthcare centers, where I see patients with medical students. So I think it's a really important experience for them to see the socially complicated patients that we have on Long Island. I also am the Associate Dean of Student Affairs, where one area I oversee is residency services, counseling students on which specialty they would like to go into. So that impacts the future. And that's it about me. John?
Thank you, Donna. Appreciate it. Thank you, Gordon. And pleasure to be here. Very excited. So my name is John Caraptis. I'm a physician assistant by trade. I graduated from NYIT PA program in 2003. From there, I worked in critical care and cardiothoracic surgery for 15 years. I had the opportunity to be a director of quality and education for 4 years within a large institution on Long Island. I also worked in medical informatics for about 2 years. And currently I'm director of surgical services and digestive disease at New York Presbyterian Hospital. And typically what I've been doing now with developing the workforce is more in the non-clinical realm. I've been tutoring leaders, clinical leaders that basically want to make that transition to administration or leadership in some of the non-clinical pieces of healthcare, mainly patient experience, efficiency, billing, coding, things of this nature that you really don't get that sort of education in general, whether you're in medical school, nursing school, or PA school. So that's currently what I'm doing. So thank you, and I'll hand it over to Dimitri.
Good morning. Unlike my predecessors, I'm the rookie. That's probably why I'm going last. I graduated NYIT in 2015 in a nursing program. I am a nurse by trade and forever will be a nurse. My background is in lab technology, but that wasn't in NYIT. That was my previous career. So after graduating NYIT, I started working for Northwell Health as the ICU nurse for 2 years. Then I transitioned over to an assistant nurse manager. For the past 6 years, I've been in leadership, and just recently I was just promoted to director of nursing. So I oversee 3 nursing units, a telemetry unit, oncology unit, and a surgical unit currently at Plainview Hospital, Northwell Health. My affiliation with NYIT, it never went away because I still teach as an adjunct professor as well. That's why I love NYIT so much. I'm always speaking with Mr. Gordon and Dr. Sparacino in the nursing program. I teach nursing students both in the didactic portion and as well as the clinical setting as well. So I think nursing has a great deal of making a lot of changes. It starts with us, like Maya Angelou said, is be the change you want to see in this world. So that's my philosophy in life, and basically as a professional, those are my professional values, and I'm happy to be here today to contribute to this panel.
That's phenomenal panel, as you can tell. They're very down to earth people who are practitioners, and that's what I truly like about this group today. My background is I come from Canada, went to Montreal McGill University in a degree in education in the kinesiology realm, came to the United States in the 80s and did my doctorate in physiology of human performance. And beyond that, I spent 10 years in Asia working on a university that didn't exist. Coming back to the United States was my motivation to get back to my roots and to see how I could make an impact in people's lives. So I worked for the police department for 5 years in Indiana, and then came to New Jersey first, and then to NYIT in 2017. Something that I'm really proud of in the workforce development is we teach 800 students in my program. Donna's program in COM has about 1,200 to 1,600 if we include the groups that are in Arkansas, our branch campus. And what we're looking at are the fundamentals, nursing from the undergraduate leading into an NP program, PA at a master's level program, but obviously they have to get through the undergraduate program. They're very highly subscribed. Many students want to get into the program, very long wait list to get in. And then the occupational physical therapy programs, as well as our undergrad programs in exercise science and health. So one of the things that we tried this past year in workforce development was we applied to the Long Island Regional Economic Development Council, and were given a grant that was administered through the New York State Department of Labor. And of the 1 year that we put this into implementation, we hoped that we would find probably 270, or it's a nice round number, of people who were not employed, looking for employment. But our target group were military veterans. The second group were those with autism or people who had a disability that might prevent them from even thinking about a career in healthcare. And the last group would have been those who are underemployed. They may be working in a hospital system and just say, well, what's my next level? What can I do after that? So of the target of the 270 people, we met our goal. We were exceeding our goals because there's a great demand. So I'm going to turn it back to the panel, and let's just keep the same order. And I'd like you to review with us in your discipline what it is that is your current status of the workforce. Is it something there's an oversupply of practitioners? Is there a lack of workers? Or is there an equal balance of the workforce? And do you find that people are leaving or entering the profession? Back to you, Donna.
Okay, Historically, as osteopathic physicians, the emphasis is on primary care, which includes internal medicine, OBGYN, pediatrics, my specialty, and family medicine. And at NYITCOM, about 53% of our graduates do enter primary care, and the rest of them enter these subspecialties. Many of our graduates will be trained in the tri-state area, and many of our graduates will stay on Long Island because of family and because of access to everything we have here on Long Island. In fact, many of you that are involved in today's program may have an osteopathic physician as your physician, whether you realize it or not. So many of our alumni stay in the area. Where we have a need and close to my heart is in developmental pediatrics. Those professionals who evaluate and treat children with developmental disabilities are on the autism spectrum, and we know there's a big need there. We need more pediatric neurologists, and we need more psychiatrists who are able to have a large impact on the community instead of just in small private practices that don't accept any insurance. So what we like to do is scan the environment and then guide our students appropriately.
Great, Donna. Over to John.
Great, thank you. For the physician assistant market currently in New York, the supply is basically meeting demand. When you go to other parts of the country, that's typically not the case. In the Midwest, South, Southwest, typically there aren't enough PAs for the demand of jobs. But right now in New York, it's meeting. What we're gonna see in the future is it's probably the supply isn't going to meet the demand of jobs because there's going to be more and more physician assistant jobs. Again, typically because physician assistants as a physician extender are considered, you know, I hate to kind of say it, but cheaper alternatives to hiring a doctor. There are going to be more and more positionings opened up. So the supply will not meet demand in the near future. Obviously, New York is a marketplace with a ton of physician assistant schools, similar to California. So typically where you see a lot of schools, there's going to be a lot of supply, which is good. So that's what we're seeing now. In some of the ancillary areas of healthcare, particularly respiratory therapy, anesthesia technicians, lab technicians, there is a severe shortage currently for these positions in hospitals. And it's actually a very big problem. There's not enough training programs. The current training programs aren't large enough. So that is an area that's going to have to be looked at. And people are even looking at things like automation now for some of those positions because there's just not enough. So that's what's going on now.
And I must add that I agree with John, especially when it comes to the nursing world. You know, the pandemic has taught us a lesson as far as the shortage of nurses. I was recently quoted as saying that prior to the pandemic, employers like Norfolk Health, Catholic Health System, and the NYPs of the world, they had the upper hand and select the nurses that they wanted to get. But nowadays, the nurses have the upper hand in the sense of negotiating their salaries. So we are seeing a shortage when it comes to the ancillary staff, as John alluded to, with the nursing assistants, the nurse techs, the ED techs. There are not that many programs. So we have seen employers working with those respective unions to basically have little small programs geared towards these getting that support for those ancillary department. My hospital is currently working in as far as training nursing assistant, basically individuals that has no nursing assistant background and offering them a job. So as John alluded to, the supply and demand for nurses is not really there. We are in a shortage of nurses, as you guys know, that we have an aging population, so all of that takes into accountability as far as how we see that much shortage when it comes to the nursing world. So I do see it becoming a problem for us, as it already is right now because of the selection processes. But I do know from the workforce standpoint, it's going to be we have to start prepping ourselves.
That's great. And Dimitri, can I follow up with a little bit of personal insights? So the racial and economic disparities of healthcare workers is very prominent in some disciplines. And some people of unrepresented roles may not be affected the way that other people are in other roles. Do you have any insights onto the whole aspect of illness and disease in disparate populations?
Yes.
Anything you'd like to comment on that?
Yeah, so that's a big issue within our healthcare system now. So working at Plainview Hospital, we have a different population setting that might be coming up to Plainview Hospital. So I remember from my own personal experience working in the Bronx, that was totally different, right? Although that's not Long Island driven, but we have communities, small sectors within Long Island that's not getting the appropriate care that these individuals might need. So my personal experience with someone that was from the Bronx, I was speaking to that patient about diabetes. It was as if diabetes was inevitable. It was just like, I was just like, hey, do you know about diabetes? Oh, I don't have it yet. That was the answer. That was the answer that I was given to me by a patient. We have those little small pockets here on Long Island, different sectors that's not getting that appropriate field as far as healthcare to be promoted. Like I think Dr. Donna Marie McMahon speaks to Central Islip, I live close by there, so I know that rural area. There are some small pockets of underserved population that we need to be able to bring that workforce there in different sets of things. I know hospitals are working as far as having that the cultural nursing, cultural sensitivity, and being able to teach people from different backgrounds the challenges that those individuals might be dealing with on a day-to-day basis.
And that's something I know Dimitri learned in our nursing program. We concentrate on the transcultural nursing theoretical underpinning. So you might, at the current time, have the Easter, which is a very special time in the Christian religion. You have the Passover in the Jewish religion. We have the Ramadan going on, and different food and different times for fasting all affect the healthcare population. Certainly those who are practitioners and the others who are the patients and might need a different type of food or a different type of accommodation for prayers at a certain time. So I think we all have to be attentive to that very special area. So let's divert a little bit from that conversation and go to how do we shape a new employee? So tell us a little bit about your institutions. We'll just open up to any of the people who would like to speak in any order. Are they really just thrown to the wolves or told, forget everything you learned in school, we're going to teach you the way it is that really is that's out there? And is there a more methodological approach to workforce development? Anybody want to weigh in on that?
I can start. In the medical school, it's 4 years of training. And during the first 2 years, their preclinical years, the medical students are exposed to simulation lab, where we have actor patients. They're being videotaped. The patients have specific problems. The expectation of the students is to understand their problems and be culturally competent. And they have training within those 2 years so that we can prepare them to go out into the clinical settings in their 3rd and 4th year, where they will be in hospitals or outpatient settings. And thankfully, now residency programs have picked up on the importance of cultural competence and meeting patients where they are. When I trained, and before me, imagine there was training before I was around, it wasn't about you, it was about me. And now we finally turned the tide, and it's about you. It's not about me. And so I'm happy to say that I can see it within the institution, and I can see it certainly with our students, that they see the importance of that cultural competence.
I'd like to go back to a little bit of a negative. When I started working with the police department, and this was in the late 80s, the word on the street was that you were supposed to forget what you learned in the academy, and then you would be taught how it was in the car of the trooper that I was working with. So we put into place a performance system that was based on proper management procedure. So let's go over to John. Do you have an insight into how your organization does the onboarding for new employees?
Yeah, no, absolutely. I mean, I think in the past, it's been very unorganized. and it's been different on a departmental basis. Each department would create their own orientation. Now it's extremely organized and a much more lengthy process. So typically our orientation, I'll just go by PAs and let's say non-clinical or clinical ancillary staff, respiratory therapists, things of that nature. Typically you have a hospital-based orientation for about 2 full days of just lectures, just about the hospital in general, you know, typical rules and wayfinding of the hospital. Then you have a 2-week departmental orientation that's very standardized. Then you're set up with a mentor, a senior person within the staff for the next 6 months during your probationary period, which is what we call it. And at the end of that, your mentor, as well as the supervisor or manager of the department, will kind of pass you on your orientation. So it is very structured now, where I'll say in the past, it really hasn't been structured. And I think that's just because things are obviously always changing. Healthcare is changing. The people coming into healthcare, the workforce are changing. So we have to make those changes as per the people changing coming into healthcare. And I think that's why we've done that. I think people yearn for more structure nowadays. So that's what we have going on here now.
I think.
Yeah, I must agree with. Oh, I'm sorry.
No,
I must agree with John because you know, I think Mr. Gordon, what you referred to as far as forget what you learn in school. You know, sometimes I happen to tell my nurses that the same thing when they come in the unit is just, yes, you have to remember what you learn in school, but we have to give that care based on that patient's need, right? That patient experience matters at the end of the day. Not saying that you're going to have your typical CHF oh my God, but this might be some underlying thing going on. So we have to get to know our patient. And I think I agree with John as far as orientation geared a certain way. Nurses have residency program where they could just meet with other nurses that are new grads from the island, coming from different sectors, different schools, and they be able to work with that journey together for that whole year period. We do have a mentorship program from a leadership perspective that mentor will be checking on you, like a mentor-mentee training model in the sense of, hey, I could go to this person to follow them. Like in my units, I have a rule whereas the preceptor, that new nurse have to follow that preceptor schedule for at least 4 to 6 weeks after the whole orientation process. So it's just different things that hospitals are doing to make sure that they're getting that engaged workforce.
I think we're really getting into the nuts and bolts of what the system is like. If I can mention both John as a PA and Donna as an MD or DO osteopathic medical specialist, they do rotations. Our students go through blocks of periods of time when they're under the supervision, but nursing is a little bit different. So Dimitri, back to you for a second here. Tell us about your preceptor style of, first of all, level of management. Where did you come from? How did you get to the level of director of nursing? And then how do you mentor our students in a preceptor practicum that would be different from the medical model?
So from myself, so 2017, I was approached by the previous CNO at my hospital that I was working at LIJ, and said that I should go into leadership. I've always been a leader, so that basically opened up my eyes. It was either A&M route, the leadership route, or go to CRNA school. I didn't want to be a CRNA, although I was very passionate about such. But leadership has changed my life in many different ways that I never imagined. I've always been that person, as I alluded to in the beginning, that I want to be the change that I want to see in this world. So I use that same model when I'm teaching nursing students from a practicum level, from a preceptor level. My students, I always like to teach them based on why, asking the why, be curious. We have to be curious as learners. You know, even myself as a leader, I'm always asking my staff to question me, not in this, it doesn't have to be negative way. It has to be, if I say something, hey, this is what needs to be done. You know, there's always room to learn. I'm always teaching in that aspect. We have to learn. I just learned something new yesterday. I might not have known, you know, just because I've been doing it for XYZ doesn't mean that you cannot teach me as a new person. So you have to have that open mindset. That's how I teach all my nurses, that on the academia level, when I'm teaching them when I'm bringing them in the clinical setting, whereas I'm pretty sure the medical model is totally different. But again, I do believe in teaching by example, leading by example. And that's how I was able to get promoted into the aspects. You know, I always tell my staff, I have to get to know you as a person in order for me to gain you, to have that followership. It's not about I say, is we are working together at this. You know, one of my students always said, I always like your email. You always said, I'm looking forward to working with you. Not like I'm not gonna be I'm gonna be the boss. I'm gonna be the manager. I'm gonna be the professor. I'm working with you to make you be that best person that you could be.
I think Donna said the same thing, and we truly appreciate that approach. It's different than it was in the past. John, come back to you for a second again. So let's talk about how you got started, and if you could change anything, would you go into the same profession that you did? And was there a motivating factor, a person that influenced you? Tell us a little bit about your journey.
Yeah, it's kind of a silly story, but my father was born in Greece on a remote island called Ikaria, and his grandfather was the village, doctor, not a real doctor, just because they didn't have any real doctors there. And he used to tell me these kind of strange stories about his grandfather doing, different things that isn't real medicine. But they were very interesting stories to me. So I always wanted to get into healthcare, and I ended up going to physician assistant school because of that. I wouldn't change it. I think, healthcare is an extremely solid job. It's very safe. There's a lot of job security, I believe. There's always going to be a lot of jobs out there. You can find jobs anywhere throughout the country, as well as staying in New York. So I think it's great from that perspective. I think it has gotten, a little more difficult and stressful. Obviously, COVID changed a lot of things, and there's a lot of focus on mental and psychological health for healthcare professionals. So I think everybody has to be cognizant about that. And there's a lot more administrative burden on providers and nurses, whether it's with the EMR or, Joint Commission standards, the fact that now patient experience is a big thing. When I was first a PA, nobody really cared about patient experience. Now it's publicly reported, and you want to try to treat a patient almost as if they're staying at a hotel, which isn't necessarily always reasonable, but that is the truth. So people need training on that, and that does add some sort of burden as well. So I think it can be stressful, but overall it's a great profession. I wouldn't change it for anything.
I've got one last question. I'm going to leave it to my lady on the panel, and I don't mean to be sexist by this, but let's just ask, could you give us one anecdote about, that made an impact in your life that motivates you to work with the next generation of healthcare student?
I think because I came from a difficult childhood situation, a violent home life, and my family practitioner, who was a first-generation immigrant, really affected me and cared for me and my mom and my siblings. And I thought, I want to have that effect on someone who doesn't have a voice. And that motivated me throughout my entire career. And so for me to, I'm completely humbled by the fact that I can have an impact on someone's life, or potentially save someone from intimate partner violence, or save a kid from being without food. And it's humbling. And so for me to pass that on to students who come my way, that this is a humbling profession, that we have incredible power to impact someone's life. That's huge. There's no amount of money that could possibly be equal to that power.
Thank you so much, Donna and John and Demetria. Joe, thank you again for this valuable opportunity to speak with the audience on our passion for healthcare. Back to you.
Thank you, Gordon. That was quite a discussion, and it was a wide-ranging one. Covered a lot of territory, so we want to thank you for that very much. All right, so moving on now. Our next panel sheds light on behavioral health and how immediate crisis response is crucial. This should be interesting. Please welcome our panelists. Melissa Kosia, Director of Clinical Crisis and Stabilization Services, Family Services League. Jeff Stiegman, Chief Strategy Officer, Family Service League. And Bridget Topping, a police officer, Behavioral Health Unit, Suffolk County Police Department. Panelists, take it away.
So, Melissa, if you could just pull that up, that'd be great. It's really a pleasure to be here, and particularly with my colleagues, Melissa and Bridget. As you'll hear as we move forward, we've had a tremendous partnership from the outset with Suffolk County Police Department, particularly the Behavioral Health Unit. But just want to, I'm sorry, Joe. I just want to just make a few prefacing comments. Then I'm going to turn it over to Melissa. But we're really excited to be here to talk about behavioral health crisis services. The demand for such has exponentially increased, and I think will continue to do so for the reasons everyone is aware of, I'm sure, COVID and otherwise. Let me just jump right in because we want this to be as informational as possible. Family Service League, just to provide a contextual backdrop, opened up DASH, which stands for the Diagnostic Assessment and Stabilization Hub, in 2019. This was the first 24/7 crisis stabilization program in the region, and really filled an historical and an important missing level of care in the larger system, and created really interconnected crisis services that were immediately accessible and effective. And really, the program has been transformational in many ways, as you'll hear. If you just go to the next slide, just in terms of who we serve. So DASH, along with the connected services of our 24/7 hotline, which is part of the 988 Suicide Prevention Network, as well as our mobile crisis teams, serve all of Suffolk County in terms of Suffolk County residents. And we see and treat people, anyone from 5 years and above. And as I mentioned, behavioral health as that umbrella term, we will see anyone who has a mental health or substance use crisis. But, there are times also we'll just be there to provide linkage and follow up and information. But most of the services we provide are for acute crises. And obviously we work with individuals and their families. The model has really allowed us, in partnership with various stakeholders, to better meet community needs, to save lives and divert individuals from unnecessary hospitalization, incarceration. And we do that by assessing and stabilizing and connecting individuals with needed mental health, substance use, or other behavioral health challenges. And as you can see on the screen, from the outset, before we opened the doors in 2019, we planned on how we were going to develop this program with our stakeholders for over a year prior. And the stakeholders included New York State Office of Mental Health, the Suffolk County Division of Mental Hygiene, OASIS, Suffolk County Police Department, and the local town and village police departments out east, courts, and importantly, all of our sister agencies for behavioral health provider community, as well as families, clients, and advocates. And that really informed us in terms of how we wanted to develop the program. Given the success of the program over the years, and we can't believe it's 4 years already, it's allowed for a proof of concept that is really being parlayed into replicating this model across New York State, which is exciting. It's going to really build a larger infrastructure for crisis care throughout New York. So why is this important? Why is filling this historical need important? I think we all know that if you provide the crisis services at the right time and in the right setting, and by the appropriate professionals, it will result in better outcomes in the shorter and longer term. And one of our goals is to be able to move as far upstream as possible to be able to provide alternative interventions, alternative from higher levels of care, to be able to do something that's more preventative than reactive. We all have heard about psychiatric boarding and how busy the emergency departments are, and oftentimes people that go there in a behavioral health crisis, they don't get the care that they need. So in order to really re-engineer the system, we've done a lot of work to try to figure out how do we prevent someone from going there if that's not the right setting. As you will hear, working with Bridget Topping, her team, we have been extremely innovative and have really moved the needle in terms of coming up with new approaches on how we can partner with law enforcement and really just to provide the best outcomes for individuals we serve, also to remove law enforcement from what they've always been in, which is that de facto position of being a substance abuse counselor or mental health counselor, where really that's not their role. If we look at the data over the years, we've always known that, there was always a binary choice. Prior to models like this being available, it was either go to the hospital or try to access care on an outpatient basis. And if we look at all the data, that's and particularly for the comprehensive psychiatric emergency program at Stony Brook University Hospital, over 50% of the people that were brought there were not admitted, and they were released, and sometimes without a real solid discharge plan. And if we look at the CPEP data, since DASH opened, there's been a positive impact that the program has had. What I will say just before I turn it over to Melissa is that DASH has evolved tremendously since we opened. And really that's based on the wonderful staff that we have, the passion and commitment, and it's really mission driven. But it's really evolved always with the mindset of how can we improve and how can we be visionary in terms of bridging gaps, innovating, partnering. And this often has meant harnessing technology and using it as effectively and efficiently as possible, along with being data informed. So with that, let me turn it over to Melissa, and she'll speak more directly about the specific services that are provided.
Thanks, Jeff. So DASH is designed so that we can break down barriers, make it easy for people to access care, and that we can engage a variety of different individuals experiencing a variety of different behavioral health crises. The program is open 24/7, 365. We are 100% voluntary, so people coming in have to be, in agreement with getting the assessment we're providing. We don't do any sort of seclusion or restraint. We are located in a industrial park, and it's very confidential and very professional. So it's not like people are coming in next to the local Target. I always say you're not going to see people or have, a neighborhood where they're going to see people coming in and out. It's very private. We can work with people up to 23 hours and 59 minutes, but in reality, our length of stay is about 3 hours for a typical assessment, but we can work with somebody up to 23 hours and 59 minutes. If they need more support, more services, we're able to tailor what somebody needs when they come in based on the crisis they're experiencing. We have multiple family and stabilization room. I actually have slides that I could show you some of the pictures of our space so that we can, we're very flexible with the way that we use our space. Sometimes we have an individual coming in alone. Sometimes they come with multiple family members. Minors on site always have to be accompanied by an adult, and that is because we treat 5 and up. We can't, and it's an unlocked environment, so we can't have minors unaccompanied. We have lots of engagement and comfort items, things like computers, or like we have a PlayStation. We have age appropriate toys, blankets, snacks. We don't actually have beds, but we do have recliners if somebody wants to, de-escalate in that way. We also have snacks, shower, laundering facility, and we have spare clothes and toiletries. So we really have tried to embed things that create no barriers to care. Somebody comes in with bed bugs, we're able to work with them. We have a family who's homeless. We have things to help support them and get them on their feet and assess them. We have somebody who's been out on a run using substances. We're able to bring them in, help them clean up, and start talking about their next steps. We have a multidisciplinary team, which includes, I have psychiatric nurse practitioners who could provide a small inventory of PRN medication if that would help de-escalate somebody. I have registered nurses who are on site 24/7. I always have mastered level clinicians like social workers and mental health counselors on 24/7. My mental health aides are kind of like my flex staff. They do some data entry. They help welcome people in. They help with our paperwork. I also have certified peers with lived experience in both recovery and with mental health. And I also have case managers, and they help secure those linkages after somebody's crisis has been de-escalated. I always say we want to put things in place in the community. It's great that we're able to de-escalate somebody when they're on site, but really putting those supports in place on the outside is what's going to prevent them from having the next crisis. This is what DASH looks like on the inside. I describe it as like an urgent care, and I can't tell you how many parents have come with children and they feel so relieved and positive about coming in, because it's meant to be very soothing and very safe and comforting for the people coming in. These are my large and small family rooms that we could use in a variety of ways. Sometimes guests staying overnight like to stay in the family rooms because we have the TVs. It could serve for a whole family coming in. I have toys in these rooms. I have my gaming consoles in this room. So we can use them in many different ways. Sometimes it serves as an overflow waiting room when we're really busy. So lots of different uses for our space. I talked about the different crises that somebody might be experiencing when they come in. And pretty much for anybody coming in, we're always going to do a brief medical triage and a clinical assessment. We want to rule out any medical concerns. We're always going to do a brief intervention and de-escalation. There are certain circumstances that might support other interventions that we could provide. So for example, if somebody is slightly intoxicated, we are able to allow them to kind of sober up and give them an assessment to start MAT, do an MAT induction ambulatory at home so that they can start that treatment. We also can reach out to current providers, school families. We want to reach out to those supports to make sure that we are thoroughly assessing the person and making sure that they're linked to supports in the community after they leave us. And if they don't have those supports in place, we do actively establish new linkages and referrals to different levels of care depending on the person's needs after we assess them. Every once in a while, when we have somebody come in, though, our goal is obviously to avoid or to divert from going to the hospital, but periodically after an assessment, if we find that somebody does have significant mental health concerns that need the hospital setting, we may have to facilitate that referral to the ED with the hopes that they get admitted. We're not looking to just refer them for another assessment in the emergency room. We're sending them with the hopes that they meet criteria for psychiatric admission. And when we collect, Jeff mentioned we collect lots of data. Less than 1% of our assessments are referred to the ED for that reason. This is another area of the program. This is our stabilization room. So this is the place that we can kind of draw the curtains and somebody can be in a recliner and sober up and be very close. Our nurse can push out and monitor them ongoing. We can dim the lights in all of these areas. We have quiet rooms with observation windows if somebody needs more space or they need to step away if we're very busy and they need a lower stimulation environment to kind of de-escalate and to relax before we can provide our intervention with them. Okay. On the first slide, it broke down. DASH has multiple parts of the program. We have the stabilization center proper, which I showed you, the physical space that's open 24/7, 365. We also have our crisis hotline, which rings into the site, and also the mobile crisis team, and I have slides on each. So our hotline is also 24/7, 365. It's the same staff that are working the stabilization center also work our hotline, and all of the calls are handled by master's level clinician. And we typically do much of the same work on the hotline. We're doing a brief assessment, but many times on hotline, we're figuring out what other service do we need to refer this person to? Do we need to refer them to come into DASH? Do we need to send out mobile crisis to them to provide further assessment? Or is it just somebody who needs some basic information? They need community resources or referrals. We also serve as backup to the 988 system for Suffolk County and a few other counties upstate through our crisis hotline. Our mobile crisis team is one of the few parts of the program that's not 24/7. Right now, we are 8 a.m. to midnight, 7 days a week. We are working to get overnight capacity, and there are some evenings that we do have the ability to dispatch overnight. The mobile crisis team dispatches in plain unmarked cars from the stabilization center in Hauppauge to all points within Suffolk County, and the team will always be 2 staff, which will include 1 licensed clinician and then either a peer or a case manager or another clinician that accompanies that staff person. Mobile crisis goes out for 5 years old and up, and we go, like I said, to all points in Suffolk County. Mobile crisis is a little bit different than DASH. While DASH is 100% voluntary, we can go out for somebody who is unwilling or unable to receive an assessment in person. And typically, mobile gets referrals from what we call third parties. It's a family member, it's a concerned community member that is calling concerned about somebody's mental health. The team engages in the community, and we provide many of the same services as DASH, that de-escalation, the clinical assessment, and linkages to ongoing care. So I want to transition to our collaboration with law enforcement. We're running really tight on time, but this is such an important part of our work together. Around 2020, 2001, we started collaborating more with the police. Even though we always had an established partnership with them, we really expanded the work that we're doing. And I'm going to turn it over to Officer Topping to talk about those initiatives.
Good afternoon, everybody. I am Officer Bridget Topping. So back in 2021, August of 2021, the Behavioral Health Unit was created within the confines of the Suffolk County Police Department. Since then, we have really just promoted everything that DASH can do, a mobile crisis can do, and Family Service Lead can do to better help officers when they're on scene, when they're looking to go out, what they can provide for individuals that are in crisis, and really just like a multifaceted approach. Even if it's not the person in crisis, anybody that, all their collaterals, anybody that they're surrounded by that may be looking for some help and assistance. DASH also works with towns and village police departments. Those are out on our east ends. They are looking to base what we have done, this unit that we've created, being this gap between the people on patrol, officers on patrol, and DASH. I am aware that some of these other departments are now looking to kind of mirror what it is that we've created and the role that we play, because they're seeing how important it is to have police officers embedded in the department that can have this connection and have this established role. You can go to the next.
Sure. I'm going to start with, we have multiple parts of our police work, and the first two parts that I'm going to cover have been a part of DASH since we opened in 2019. So since we opened, we've always had a separate entrance for police drop-offs, which is really nice. A separate entrance really protects that person's confidentiality. They're not in trouble coming with the police. They're there of their own will getting a behavioral health assessment. So the officers use a separate entrance. We accept these referrals from all SCPD, town and village, and even university police can utilize. We do a quick triage and exchange of information with the officers, and then we start our assessment. And our average drop-off time for the police to come in and drop somebody off is 17 minutes on average. We also, since our opening, have had collaboration with police on our mobile crisis team. We engage with police on about 33 assessments per month as a co-response. That co-response can either be initiated by the police, or it might be initiated by my mobile crisis team, depending on the situation. Police may recognize mental health concerns on a call and request mobile crisis, or the reverse might happen where mobile crisis might get a request and we realize there's some sort of known history of violence, aggression, possibly the presence of weapons, and we can also call for police escort in our co-response. We can also request police if we are assessing somebody and we deem that they need a transport to CPEP. So we establish if somebody meets criteria for an involuntary hospitalization, we would facilitate that with police, and they would go to CPEP or another hospital if CPEP's on diversion. Lastly, police are always our first response if there's a medical issue on the scene, and we call 911 for EMS. So we work very closely with police on our mobile crisis team.
And then some of the programs that we've really established and have working really well since the inception of my unit has been our telehealth engagements, our cold diversion, and our high utilizer overdose program. So telehealth is an option for officers that are crisis intervention trained, where they have been issued work phones. They can engage with a licensed clinical social worker at DASH who can assess the individual and make the determination to see if that person should be transported to CPEP, can come to DASH, maybe mobile crisis will come out at a later date. Does the officer have enough of their own observations to take them to CPEP themselves? Very successful program that we have with telehealth. Our officers love it. They are using it constantly. The community loves it, which is most important. People are really seeing this collaboration between the police department and mental health field, where they're just really happy to see this multifaceted approach, very successful with that. And then our call diversion program is.
Can I just stop on?
Oh, yeah.
So sorry.
No,
I
no,
just
no,
want to
yeah.
point out that it is really successful because 80% of the calls that we have with the police are diverted from needing to go to CPAP. So we're able to kind of intervene and prevent maybe that automatic transport to CPAP that might have happened in the past with officers. And I just want to highlight, we did 543 of those in 2022, and we have such a great collaboration. We close the loop with the officers and we send them that disposition as well.
Yes.
Thank you.
No, and then, right along with those lines, we have the call diversion program that happens right in our 911 communication center, where dispatchers are trained to have some active listening skills, and they have the option to send a call over to Dash, to a mobile crisis, and have that person evaluated on the phone. If there's an emergency, if it has to go back, they can kick that call right back to the 911 center, where an officer can be dispatched to that person in crisis. It's a very successful program. We'd like to continue to see those numbers grow and increase. Melissa has some more stats here.
So this is definitely, we need to increase the utilization. We do about 8 per month. And again, we always close that loop and we send dispositional emails back to the 911 call center to ensure that there's a flow of communication between both of us.
And then our high utilizer program. This is where through software systems within the police department, we are alerted when an individual that is in crisis. If they have 3 or more PMI calls within a 6-month rolling period, we look at and assess that individual, do a write-up, a little referral on them, and send that information over to our partners here at Dash. They then make a determination of what that outreach is going to look like. Go ahead.
This part of the program, I think for me, like boots on the ground, seeing what we're actually doing, these are people who are truly falling through the gaps, and they're having, an disproportionate interface with police in the community based on their behavioral health needs. And the way that we're able to seamlessly kind of work with the police and get these referrals sent to us and engage these individuals, this is probably, I think, one of the most successful partnerships or pathways that we've established with police in the recent years. We have, I don't even think we have the number in here, but we have close to I want to say over 500
Pretty close,
referrals through this program. And we also accept referrals of individuals who have overdosed in the community. So every individual in Suffolk County that overdoses has a non-fatal overdose. We are reaching out to them and trying to send out staff to meet them where they're at and to get them to engage in some form of treatment, make sure that they have Narcan, and educate them on the services that are available. Dash is, we talked a little bit about the numbers with the new, all of the police initiatives and our additional pathways that we have established with the police. But we see at Dash about, 400 and 4,200 assessments a year. We see about 357 individuals per month. Our age range of the people we treat are about 30 to 40% minors. It's higher during the school year, lower during the summer, and 60 to 70% adults. Our police drop-offs remain about 19 per month, and about less than 1% of them need to go to an ED after coming to us. We're able to divert 99% of those referrals. Our hotline is also a very busy part of our program. We get about almost 1,500 calls per month and 1,800 calls for 2022. Our mobile crisis team sees about 1,400 assessments a month. We do about 116 on a monthly average. A mobile crisis is more adult heavy, about 90% adult, 10% minors. Our ED transports too are a little bit higher on mobile crisis because typically we're going out when somebody is more acutely symptomatic. They're further along in their mental health symptoms and they've been refusing treatment. So about 20% of those are transported to CPAP or another ED, and about 60% of those individuals are actually psychiatrically admitted. So thank you. That concludes our presentation. I don't know if we have time for a question or any questions.
I see one question in the chat real quickly. Joe, we have a second or no?
Yes, you got a second.
Okay, so someone asked what CPAP is. So CPAP stands for Comprehensive Psychiatric Emergency Program. So for instance, if an officer responds to an individual in crisis and they deem that there's imminent risk they will bring them to Stony Brook CPAP, which is kind of the clearinghouse in Suffolk County. They determine if someone needs inpatient admission or not. And then where they would go in terms of they are aware of all the open hospital beds in Suffolk County. The most important thing is that, I mean, all of our work together with law enforcement, as well as our work at DASH and creating this new model, it's been really, like I said before, transformational in terms of the change. It's allowed us to really better utilize resources. And, you know, as Melissa had stated just before, you know, it's such a significant number. 80% of the calls from law enforcement in the field do not end up going to a hospital, where in the past, the majority of them would have. So that is, you know, and when that happens, you take 2 officers out of their sector, they're often at the hospital for hours, and it just is inefficient and often not client-centered in terms of what the client needs. So anyway, hopefully that answers your question.
Okay, well, that has answered a lot of questions, I think. There was some very engaging conversation there. Thank you very much, panelists, for joining us today.
Pleasure.
Thank you.
So moving on to our final panel of the day. This today's forum, the last one will be focused on a topic that we've been hearing a lot more about in 2023 and beyond: healthcare compliance regulations for the business community. You might be asking, why does it matter? Well, our partners at Harris Peach have the answer for you. Please welcome our panelists. It's Roy W. Breitenbach, partner, Harris Peach PLLC, and healthcare industry team leader. Mark Lyon, partner, is ours. And our very own Dina Genn, reporter and my colleague, Long Island Business News. She will be moderating today's conversation. Adina, please, all yours.
Thanks, Joe. I'm assuming everyone can hear me, correct?
Oh, yeah.
Yep.
Yes, okay, good. Okay, well, Roy, Mark, thank you so much for joining us. I'm sure you have a lot of answers to questions that both healthcare providers and the people who advise them are asking. So like when we think about what doctors learn in medical school, they're learning about how to save lives, how to help their patients thrive, but they're not necessarily learning how to run a practice. Now they've got to deal with real estate and HR issues and compliance, all kinds of things. And some of them are turning to private equity firms or management services organizations to help them run their practices. And I always find it interesting to consider, like, what is it that a physician wishes they knew before they already maybe got involved in say a private equity deal or just running their own practice. Roy?
Yeah, so it's nice to have the opportunity to speak here today. So yeah, compliance is becoming a much bigger part of every healthcare provider's practice, and it's not just from the physician standpoint, but it's the social services agencies. It's really anybody who deals particularly with government agencies in healthcare or who have reimbursements from the Medicaid or Medicare program, right? And it becomes a ever increasing complex system. You can just look at some of the news reports that are out there just this week about problems in nursing homes, and they hit the front pages, and it's a lot of accusations flying apart about inadequate compliance programs, inadequate, and it quickly gets out of hand if you don't have an effective compliance program for your healthcare organization. I always say to clients, you don't want to be poster child on the front page of the paper, because sometimes the healthcare allegations become fantastic. And, kind of to underscore the the growing importance of compliance is the fact that the state, for purposes of the Medicaid program, have just enhanced their regulations for providers to have compliance programs, right? There's always a requirement that certainly large providers such as hospital facilities, diagnostic and treatment clinics, things like that have compliance programs. But those regulations have been enhanced and they now apply to anybody who has over $1 million worth of revenue from Medicaid. And what's interesting about the new regulations, which took effect just a couple of weeks ago, is that it keys everything around a definition of effective compliance program. People who are subject to the regs need to have an effective compliance program that's really designed for the provider's unique characteristics, the size, the complexity. It's well integrated into the operation, promotes adherence to legal and ethical standards, and is reasonably designed to detect fraud, waste, and abuse, right? That you're complying with all of the regulations you need to comply with. And though there are a lot of healthcare providers probably on this call who are saying to themselves on some level, why do I care? I don't have over $1 million worth of Medicaid business. I'm not a hospital, a nursing home, or things like that. But it's important for all providers because if they want to do any type of business, they want to go out and get private equity. They want to run an efficient practice. They want to talk about merging maybe with a hospital or being a group later in the day. Compliance is fundamentally at everything. You don't want the government knocking on your door with a problem. You want to nip problems in the bud. So all healthcare providers have to be very aware of compliance and the growing importance. Every time you deal with a payer, every time you deal with the government, you need to make sure that you have an effective compliance program that kind of sets the rules of the road and let your staff know what to do. It even goes into the whole issues of workplace now, right? There's so much turnover in the workplace, so much need to get people into the workplace. So many practices are having new people in roles that they never were in before. And that's all danger signs where there can be healthcare compliance, fraud and abuse issues, not for any malintent, but because people just don't know. They're thrown into a role and they're doing things outside their comfort zone. So that's why things like compliance, education, training, and things like that are so important.
Mhm. So Mark, do you or how do you advise your clients to actually be educated about you? As Roy painted, there's all these different regulations coming up and new regulations. How do you recommend that your clients, whether they're big or small providers, stay informed?
Yeah, Dana, thanks. And thank you, Long Island Business News, for inviting me to contribute to this program. And Roy kind of hit it right on the head. And you said something very important earlier today. Our current day physicians, they go to medical school to learn how to become physicians, but not necessarily business owners. Okay. And they don't teach business, although I am hearing here and there that they are starting some programs here and there where they do teach some portions of business to the younger folk who are coming out today, but they don't teach you how to run a business. They don't teach you how to start a business. And I can go back to, and I still have some clients that come out today and who will have that entrepreneurial spirit to start up their own practices. And we literally probably have about a 6 or 7 page document checklist. Here are the things that you need to do to start up your own practice. And this is a good guide even for a new practice or maybe even an existing practice, because part of that checklist is not only getting renting your space and buying the supplies that you need and equipment, but there's also a lot of regulatory components to that practice, to that checklist. What forms do I need in place? How is my patient intake working? And there are also checklists to train your staff. Roy brought up earlier, about employee turnover. We're seeing it's really affecting every industry, but certainly in the medical space, in the healthcare industry, we're seeing a lot of employee turnover. It's hard to keep good people. We usually like to have some form of job description or let's call it job function. Whereas if you're shifting people around within a practice, here's a written here's a written outline of what each position needs to do in their particular role, so that if you need to cross-train people, or if you need to have somebody come in, or you're encountering employee turnover, here's the list of things that they should follow as to how to do their job, right from coming into the office in the morning, turning on your computer, and dealing with security issues and cybersecurity issues. All these things come into play within the compliance realm.
So that's, are you speaking more about the administrative side, or actually everybody? Because I guess everyone's using computers.
It's really everybody.
Yeah.
Everybody needs to follow the compliance rule, and every practice should have their own compliance program and compliance officer. To Roy's points earlier about establishing compliance program. But again, we're seeing, and it doesn't seem to be slowing down. And Ray, you can weigh in here, but we're still seeing a good bit of consolidation in the industry. And this is where having a good compliance regulatory program in your practice comes into play, because if you are going to entertain, an offer from a private equity group or a large practice that's backed by private equity, some of the things that they're going to come in during their due diligence exercise, and again, that's probably going to be about a 5 or 6 page document of checklists of things that they're going to want to look at. And it might only be a page or 2 of financial information, and the rest may be more focused on regulatory, employee issues, compliance issues. Do you have these things in place? And if you don't, or you haven't thought about them before, this also can impact the valuation for the practice, and so that's why it's important, from that standpoint, when even entertaining a potential sale in the future.
So it helps you not only run your practice better, but makes you more attractive, perhaps.
Yeah, I mean, it's running. Think of it in terms of setting up your franchise prototype. Okay, if you're going to set up another office down the street, you want it running efficiently, but to do so, you want your home base running efficiently, so you can expand on that elsewhere. So it's really about getting your house in order. And usually, what I'll tell physician owners or a group practice before they even entertain a potential exit from the practice or a potential sale or roll up is get your house in order. Okay, get it per se Shark Tank ready, because what's going to happen is you're going to get a guy like me who's going to come in and really check under the hood and look at all the little items and potential deficiencies in the practice that I can utilize if I'm representing the private equity group, that I can look at to that may basically impact your valuation.
Right. So Roy, what about, I was a little, I guess, I'm not in healthcare, so maybe that's why it surprised me, but that there's regulations even with the real estate, right?
If
you talk about that.
Yeah, so even if you're, so for example, even if you're you're simply a real estate investor and you're looking to, maybe a lot of real estate developers and real estate investors are looking to partner in some of these medical buildings and things like that, joint ventures out there. And they're all great opportunities. They do great. Obviously healthcare is a growing industry on Long Island, always going to be in demand. It's a good, I think most communities like the space because it's a great, it's a great use of space and everything. But you have to be cognizant of the fraud and abuse issue, because if you're going to partner with a physician or a healthcare provider to build the space, there's all kinds of issues. If you're partnering with a group of healthcare providers and those group of healthcare providers actually have or potentially could have referral relationships among them, that could impact on things like the lease terms, rent, valuation, because so many of the healthcare fraud and abuse laws are meant to capture, get people inducing referrals or inducing kickbacks or things like that. And the government agencies look at lease and rental agreements to make sure that they're not just a artifice to disguise kickbacks between referring healthcare entities. So, if you're going to get a hospital, let's say, to invest in your building, it may impact who can be a tenant and what the terms of those deals are. and to you may have to have a healthcare attorney look at it to make, or somebody like Mark who's in the area knows how to do the compliance, and to do a fair market valuation to make sure that the leases are at fair market value, the terms of the joint venture are at fair market value, because if they're not, you could have an issue with kickbacks or some type of payment for referrals. So so a lot of things, it's not like entering into a lease with a store in which a landlord can take a percentage of the cash register, right? It can't be based on volume, things like that. You may need to do fair market valuations. You may need to have a more elaborate structure to take into account some of the financial issues. So I think anybody who's going to do substantial business or investment in the healthcare space needs to understand what the healthcare fraud and abuse laws are, so that they can.
When you say referrals, what do you mean? Like,
so if I'm a doctor, if I'm a cardiologist and I'm referring somebody out for have an echocardiogram to be read, okay, you have to make sure that the reason why that, and there's a super simplification of the rules,
right? Yeah.
Most complex rules and probably in federal government, right? You have to make sure that the reason why the cardiologist it's not the only reason why the cardiologist is referring to the person who's going to read the echocardiogram is because they're in business together.
I see. Okay.
And that cardiologist is going to get a payment for that, right? Is going to get compensated for that or something,
So
right?
that would be like a tenant in the building kind of thing? Is that
Yes, absolutely.
Okay.
So like, it was very common back in the old days to say, well, okay, you want to come in and you want to read something you want to read the echoes, well, pay me rent. I'll rent you space. I'm the cardiologist, I own the building.
Right.
I'll rent you space. And if it was $20 a month was the proper fair market value for that, you're going to pay me $40 because I'm going to give you a stream of referrals. So
But
the government wants to make sure that it's $20, not $40.
Okay.
That's one of many examples.
Okay. But if there's no kickback, that's fine, right?
Well, but
right? No.
You have to. The laws are strict liability, have exceptions and sub exceptions.
Okay.
So what has to happen is you have to have somebody who's well versed in the laws and regulations to structure the transaction in such a way that you fall into what the government calls safe harbors, where there's no issue.
Okay, because it seems like if you're telling me you need an EKG and it's right next door, I'd be happy, right? Because
you should be, but again, you have to make sure that
you're not thinking about
there's not an abusive or what the government deems to be an abusive relationship. It's intended to control healthcare costs, to preserve patient choice.
Right.
There's a whole bunch of because if you're the referring cardiologist and you're going to get an extra $1 every time you send out a read, or you're going to send everybody out for a read, you may, and that's so. It's a complex series of law. And what Mark said too, Mark talked about how if you're looking to sell your practice, and there's a lot of private equity money, a lot of private equity interest in healthcare these days, right? It's the big thing. Why are they sending those 5, 6, 7-page questionnaires, the smart private equity? They're doing it because they know that there's a risk there, right? There's a risk there. They could lose part of their investment if there's a compliance problem. There is a risk that they could be held personally, they could be held liable if there's a compliance problem, if they're an investor. So anybody who's in the position of doing business or investing in healthcare should take the same position as the private equity firms, right? Get in, understand what you're doing, know what you're dealing with, make sure that you understand what the laws are and what you can do and what you can't do.
Right. Well, Mark, what about do you advise practices that are looking at private equity firms?
Almost every other day.
Okay.
We have I had 2 or 3 two just closed. I have a couple more transactions that we're in the middle of. But to round out even a little and bring it home a little further, as far as Ray's comments went, let's just focus a little on in New York. you're following, and in many states in the country, you're following corporate practice medicine. Okay, and what that dictates is that a clinical practice is owned by clinicians. Okay, so if you're gonna bring a non-clinical, like a private equity group that is not owned by physicians, there's a contractual agreement as to the way this is set up, and this is where MSOs come in, a management service organization that establishes a contractual agreement with the clinical practice. I mean, we could probably do a whole day conference on this, but to Ray's point earlier, Ray mentioned fair market value. That contractual agreement and the reimbursement from the clinical practice to the management service organization is based on what we call fair market value agreement, facilities and administrative agreement, where the clinical practice is essentially reimbursing the management service organization, which is really run by the private equity group. I'm simplifying things here, but you get the picture.
I appreciate
And
that.
that agreement is dictated by a lot of compliance, a lot of regulatory, and it needs to pass the SNP test so that you don't run afoul of any issues within the regulatory environment. And so what we'll do often is we'll work on a fair market value analysis per se to show that a contractual agreement falls within regulatory parameters to kind of simplify it. And so yeah, these transactions we've been seeing them quite a bit. There's a good bit of roll-ups going on right now, and yet I still have young physicians who are coming out and want to start up their own practices. And there's really a whole bunch of things that need to be looked at if you are going to look at a private equity transaction, right down to how your business is structured right now. I have some groups that are thinking about it in the future and maybe not ready yet, but they actually may establish, they're establishing their own management service organizations, because that may work towards some tax efficiency in the future as to how they're going to establish a transaction in the future. And again, that's, we could do a whole nother session, a whole nother day on how to structure these things properly. But you got to, Ray said it before, you got to be careful, as far as the physicians or the physician owners who are going to sell, and then the private equity group coming in, as far as maintaining, and managing any risk that could exist out there. And here's the other thing: sometimes it exists and nobody even knows. You could be doing something, or you can be. A lot of times, we'll look at the billing practices or what we'll call the revenue cycle of the practice, and something could be done in error, and the practice may not even know, and it doesn't even come up until there's a due diligence exercise that's done on the practice, and then all of a sudden you have this other regulatory issue. Ray, I'm sure you've seen that happen before.
Absolutely, yeah.
Well, how do you just, is there like a checklist to see, like, if your practice is in like shares the same philosophy as the management? Is that even like a thing? Where maybe they don't align, values don't align, or they don't.
Well, that's, yeah, absolutely. I mean, and that's a lot of what I have done through the years is counsel practices, and both before going into private equity and even after they go and they sell their practice to a larger entity or do private equity. You have to be psychologically ready for that, and you have to make sure that private equity firm is a fit. You have an understanding of exactly what they're going to do and what they're, there's a whole psychology behind it. It's even when some of these the practices sell to hospitals, which is a pretty common thing. The health systems all buy up practices,
right?
And one of the things that I say to them is, you have been running your own practice for however many years, 25, 30 years. And I know you're getting, a substantial amount of money from whatever health system it is to purchase your practice. And that's great, but but that's what the expectation, you're going to continue to practice there for 5 more years or whatever it is. And then you have to ask yourself, are you comfortable? Because in a hospital environment, it's unlike private equity. In a hospital environment, since they're a regulated licensed healthcare entity, they really can control all aspects of your practice. Are you comfortable? And that's great sometimes, because you're being run by a healthcare organization that's a not-for-profit that's interested. So, they're oftentimes great fits. But, are you now all of a sudden comfortable with having a business person behind you counting beans, counting, looking at your efficiency, telling you, well, wait, well, you're not seeing enough patients in an hour, or, I'm not sure you need that new piece of equipment that you might like this year. It's not gonna, it's not gonna pay off, or, you don't necessarily need your own medical assistant or whatever it is, and that's, that's something that they, because that's when the private equities come in and when the systems come in, they believe that they can use the clinical expertise and generate efficiencies. That's the whole secret sauce of the private equities, right? They're going to roll up these practices together and create efficiencies. But, in creating efficiencies, are you comfortable with that? Is that something that you're willing to do? And and I think it's like anything else. You have to understand philosophy and what they're doing, and how they're doing it, and whether you buy into it.
Well, I guess it's a trade-off, right? Mark,
absolutely.
Yeah, I mean, Roy's really hitting the nail right on the head. I mean, really what needs to be embraced and understood is this the right move for the practice moving forward, especially if you have a variety of ages with different partners within the practice? How will this look and feel 3 years down the line, 5 years down the line, and not to be so enamored with just the dollars that might be offered to you, because often, really what's happening is you're managing risk. Okay, and when a group is coming in to potentially take over your practice, they're going to pay you up front. Part of that pay up front is potential future earnings that you may have been achieving in the future. So you got to kind of think about that as well. But how will this look and feel down the lines, and how will it look and feel for all the partners within the practice? That needs to be considered as well.
Well, Roy, do you advise people that want to stay, or actually both of you, do you advise people that just want to stay independent? There are some that have been part of a big system and just said, the hours, it's too much from, I have that pressure of having to see X many patients, and I'd prefer to practice, the old style country way, perhaps it's.
So a lot of my clients and our clients in the healthcare industry team at Harris Beach are practices who decided to kind of go independent, to reach a certain size, and then decided that they were going to try to make a go of it. And and some of them are successful, but it's a daily struggle. And with revenue cycle, and particularly reimbursements, and managed care contracting and things like that. So there's definitely, they're out there. You could just look on Long Island and see those practices, but it's a harder environment.
Yeah.
You have to understand you really have to understand what you're getting into, and understand what it's all about.
Are you seeing that as well, Mark?
Yeah, I mean, I'll because I know we might be banging up against time. I'll leave you with this. I mean, listen, to run an efficient practice takes a lot. Okay, and it's about creating a good form of accountability within the practice, with your group, your partners, your employees, and also establishing a good system of measurement, if you would. And when I say measurement, I don't mean just your profit and loss statement that you're looking at, that your accountant puts together, but also establishing proper KPIs that will provide you with some insight as to when and where your practice may be running off the tracks. So you want to kind of keep things going. And it's just really because most businesses, and especially in healthcare, will encounter what I'll call profit leaks. And those profit leaks don't always materialize in your financial statements. Sometimes they're in the throughput of the practice, what we'll call the revenue cycle, from the minute the patient comes in, establishes, gives you their insurance card, right up to the point where you're collecting on that patient for providing the service. There's a lot of dysfunction that can go on in the middle of that. And there's a lot of KPIs that can be established to identify when and where that may be happening. We just actually did a KPI presentation to another healthcare association, but that would be, the first and foremost thing. It's working on your business instead of in your business. You got to take the time, and it's very difficult to do sometimes because you're getting caught up. You turn your head and all of a sudden it's 7, 8 o'clock at night and I still have to do my charts, right? You know, but carving out the time to work on the business and not necessarily in the business all the time.
Yeah. Okay, that's a good summary. Roy, do you have any closing thoughts as we're about to close out?
Yeah, just, look, compliance is not I'm sure that's not why you went to medical school or PT school or things like that, but it really is something, if you want to get the ability to practice right, it's really something you have to think about, and you have to establish a culture. And it really has to be the foundation of everything, no matter how small you are. You don't want to have to pay me or my firm thousands and thousands of dollars dealing with a governmental investigation when you can, and the stress that causes when you can have a good compliance program in place that protects you against that, and also, kind of protects and enhances your valuation, your business valuation for the future. So really urge everybody to, kind of go back and really think about that, and really make sure that, you have an effective compliance program for your organization, your practice, that is really matching what you're doing and getting that in shape.
Yeah, Dana, I'll add, there was a question in the chat. A KPI is a key performance indicator.
Okay.
Which can be a whole number of different things.
Do you want to just give us a quick, can you give us a quick?
Average, your aged accounts receivables, average day that, average amount of days that your AR is sitting out there. It really could be, you can measure anything in a practice, how quickly you're turning over your patient wait time. I mean, there's all sorts of things, and then there's the financial ratios as well.
Well, it's a perfect example of why you need advisors if you're running a medical practice or any kind of healthcare practice. So Mark and Roy, I appreciate your time and sharing your insights.
Thank you.
Thank you.
And thank you, Adina, and our friends at Harris Beach for a rather informative discussion. Enjoyed that a lot.
Thank you.
Thank you. So that actually concludes our 2023 Healthcare Forum. I encourage you to check out this Friday's edition of Long Island's Business News, where we'll be doing a recap of all the panels you've seen today. You'll also be able to learn more about today's speakers by checking out our special speakers guide, which is inside the April 14th issue of LIBN. Thank you again to our outstanding partners who helped make these sessions so informative. Our presenting sponsor, Catholic Health, and our partner sponsors, Harris Beach, New York Tech, and Central Nassau Guidance and Counseling Services. Head over to libn.com/healthcare forum to catch the recording of this year's discussion, as well as our full one-on-one interview with Dr. O'Shaughnessy. Thank you for joining LIBN for the 2023 Healthcare Forum. We hope to see you soon. Thanks for watching.